It's a difficult question to try to figure out what someone's renal function is and do they have acute kidney injury. This is really a problem in the intensive care unit. We've got a patient who's maybe not making urine, and you're saying, why is that the case? This patient's got sepsis. Does this patient have enough fluid on board? Do they have acute kidney injury already? If they do, why do they have it? And our traditional markers for renal function generally are BUN, blood urea nitrogen, and serum creatinine. However, those are pretty terrible markers in the acute setting. They're great in the outpatient setting. They're great when someone's at steady state. We have all kinds of equations that we use with the serum creatinine, the Cockcroft-Gault equation, the MDRD, which is what's used in most hospitals. So when you look at a patient chart, they'll say the eGFR, the estimated GFR, it's based on the MDRD equation. But those equations were based on a steady state. That somebody who has had this normal steady amount of renal function, maybe not normal, but a steady amount of renal function. They've been making creatinine just as quickly as they've been getting rid of creatinine, and these equations do a nice job of making an estimate of what someone's GFR is. But in the acute setting, they don't work anymore because we're no longer at steady state. So the problem is that you have all of a sudden an abrupt cessation of any clearance, any GFR, and creatinine is not being cleared anymore. And urine output might be close to zero, but the serum creatinine hasn't had time to move up at all. So you may have an anuric patient who's got a normal serum creatinine. And if you use those traditional equations, the Cockcroft-Gaults, the MDRDs, all these sort of things, they totally miss the picture of what's going on with your patient. In fact, your patient's got acute kidney injury, but you don't see it because you're applying the wrong equations. And there may not be any equation that can work, to be honest. The problem is, what if this happens really acutely? What if some very traumatic event happens and GFR goes just about to nothing? Again, serum creatinine hasn't had a chance to move. There's no equation that's going to fix that. And your best marker might just be urine output. Some people have given a furosemide stress test, where you give a dose of furosemide and look for 2 hours to see how much urine gets made. And if no urine's being made and the patient's adequately hydrated, then you know you've got bad acute kidney injury and you need to adjust your doses right now correctly. The other thing that kind of messes with clinicians is the fact that often the patients who have acute kidney injury in the ICU often have sepsis. They've been filled up with a lot of fluid, and actually that fluid overload dilutes out the serum creatinine. So serum creatinine goes down in these patients who've been resuscitated, who are anuric, and you look at that serum creatinine and you say, gosh, it's only 0.8. It's a low normal value, and yet the patient's anuric. They're in acute kidney injury, and you need to adjust your antibiotic doses appropriately. Now, maybe one of those adjustments is that with all that fluid on board, you have to give a big loading dose. That might be one of the adjustments. But then how often you give the doses may have to be extended because your patient's in acute kidney injury.